Good evening, everybody, and welcome to Bloomberg Nursing's 6th annual Verna Huffman Splane lecture, an event that has been made possible through the generosity of Dr. Richard Splane and the Splane family. And before we begin, I would like to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we are very grateful to have the opportunity to work and learn on this land. It's wonderful to see those of you who are able to attend in person as your busy schedules allow, and to the large number of you who are tuning in online, welcome, and we're absolutely delighted to share with you all this important lecture on health inequity and the importance of our role as nurses in addressing this challenge across society. Throughout her career as a public health nurse, Verna Huffman Splane was known for her contributions to health policy development and planning at the national and international level, as well as her leadership in championing nurse leadership in these areas. A recent webinar hosted by the International Council of Nurses and attended by nurses from over 100 countries also highlighted the importance of nurses and their leadership in advancing access to primary care and helping to achieve the World Health Organization's goal of universal healthcare coverage by 2030. Part of the strength and leadership of nurses in providing accessible healthcare is not only their unique skill set, but also their ability to provide care holistically. Tonight, our distinguished guest speaker is a firm believer in a nurse's capacity to care for the whole person and to look beyond their disease or condition, helping them navigate bias in the health system and the burden of health inequity. Like Verna, he is a leader in health policy planning and a prominent advocate for social justice. Dr. Vincent Guilamo-Ramos is the former Dean of Duke University School of Nursing, where he helped to align the school's strategic direction in support of social justice and addressing health inequity. He has recently accepted the position of Director of the Institute for Policy Solutions at the Johns Hopkins School of Nursing, a new health policy, research and practice institute that aims to transform how nurses can lead change in the US healthcare system. A distinguished professor, Dr. Ramos also founded the Center for Latino Adolescent and Family Health at Duke, where he led the development of the Framework for Harmful Social Determinants of Health Mitigation, an innovative roadmap for educators, practitioners, researchers, policymakers, and other stakeholders who are designing programs to mitigate these harms. Dr. Guilamo-Ramos is a nurse practitioner, duly licensed in primary care and psychiatric mental health care nursing. His research focuses on improving healthcare access, quality, and outcomes for Latinos and other populations experiencing structural adversity, and with a focus on mitigating the mechanisms through which the social determinants of health shape health inequities. He's published over 100 manuscripts in leading peer-reviewed scientific and health journals, and his work has received national media attention in outlets including the New York Times, The Guardian, and Newsweek. Following Dr. Guilamo-Ramos' talk, we will open the floor for a Q&A discussion with opportunities for both our live audiences and those online to ask questions. Please join with me in welcoming Vincent to the podium.
Good afternoon. Can everybody hear me okay? So what a fantastic introduction and a warm welcome from Dean Johnston. Linda's simply delightful. I had a chance this morning to have breakfast with Linda, and she spoke so highly of the school, the profession, and all the work that is happening here collectively around health equity. And so thank you all for being here, and I hope that at the end of my lecture that we'll have a chance to have a really interesting conversation about what this all means. So with that, I'm going to jump right in, and let me know if there's anything that you'd like me to clarify, if there are aspects of what I share that don't make sense or that do resonate. We'll have time to talk about this. So I want to start by just really framing Verna Huffman Splane. And so I will be honest and share that prior to this invitation, I wasn't familiar with Verna Huffman Splane. And so I did some research trying to learn about her life, and I was really just simply in awe. I was amazed. And so she clearly has played an important role in Canada. She was the first principal nursing officer. You can also see that she was a nurse scholar, a mentor, an advocate, and that she focused on global public health and elevating the role of nurses in policymaking. And so I just want to repeat that, elevating the role of nurses in policymaking. She was collaborative, she was interprofessional, and I think I've mentioned some of the attributes that are below, but in terms of her contributions, you can see here that she really was quite rooted and grounded in social justice for communities, for individuals, for families, and for advancing health equity. These are all things that resonate quite a lot with me. I'm happy to say that Verna wasn't alone. We know as a community of professional nurses that nursing has been deeply rooted in social determinants and advancing health equity for quite some time. Just a couple of examples, certainly the Council for the Advancement of Nursing Science, as part of one of their national conferences a couple of years ago, there was an entire conference that really was looking critically at how do we advance the important role of social determinants of health in achieving health equity. We know that the Future of Nursing report, both the first one and the sort of one that we're currently operating under, also mentioned health equity and social determinants of health. There has been a lot of work around the new National Institute of Nursing Research, which has implications certainly for the US, but also for folks that are working in countries where they are eligible for applying for those funds, that the strategic plan has been realigned to more squarely address social determinants of health. I see here that the Canadian Nurses Association also has a position statement on social determinants of health, and there was a special issue that the American Journal of Public Health put out some months ago that really highlighted nursing's contributions to social determinants of health. So all of this to say that my lecture today is not new. I'm not the person that came up with these concepts. I'm simply mirroring back to our terrific global nursing community that we have been doing work on social determinants of health. What I hope to do today is share a little bit about my own trajectory, my own path, and then what I bring to the ongoing commitment that our profession has to addressing health equity and in particular inequities. So what you see here is a little bit of my own experience. I think I understood correctly from my breakfast with Linda that the program has a professional entry program into nursing that is a second degree program. And so I was someone who actually pursued that trajectory. And so I started my career in social welfare. For many, many years, I worked as a social worker, and I'm proud of that. And the reason why I was drawn to social work was because of the core belief in social justice and the belief of people having challenges that we face as being a function of our interactions with broader systems, whether they be institutions or broader policies or larger macro issues in society. I was always interested in structural drivers. I became interested later on with integrating public health, particularly epidemiology, and trying to bring into my sort of philosophical and values base some science around how do I understand distribution of disease and ways to prevent that. I later entered nursing and really brought to nursing not an abandonment of social welfare and public health, but what I saw as being an integration of public health and social welfare. And to me, it has been a natural marriage. Those three components have really served me well. And I will say, and I say this with a smile, this may not be true in this audience, but I will say that there have been individuals and institutions along the way that have kind of challenged this trajectory and said, well, you're not exactly the traditional nurse. And I want to say today, I'm proud of that because I think and I hope that more people that choose a career in nursing will not be whatever it is that one is when you're the traditional nurse. All nursing, all options, all pathways are part of what we should be achieving. On the lower left-hand side, a little personal connection. It made me think about Verna Huffman Splane. That's my mom in the 1970s. She was, in my view, she was kind of a looker. I know it's weird to say that about your mom, but she was a looker. And that's me on the far left, and then my brother on the far right. And we grew up in the Bronx, which is New York City's most disadvantaged borough. And the reason why I mention this, because a lot of my experience as a child growing up has really shaped my career and how I view nursing, how I view health, and how I view what I want to do and what I've been doing in terms of my career. So I'll talk more about that. I want to start by officially launching into what I hope to share with you all tonight, which is really my sort of understanding of a synthesis of what, in my mind, is the work that we should be doing collectively as a nursing profession. So I want to start by talking about health inequities. In my mind, I don't use the word disparities. I intentionally use health inequities. And the reason why I do this is because these are systematic, clustered sort of differences in health outcomes that are not just simply differences, but they're rooted in unjust, unfair social processes. And I think the word inequity is what I understand as being what I commonly see in my nursing practice. There are three things that to sort of define those inequities. One is health status, and typically we're talking about morbidity and mortality. They're exemplars of health status, but they're not the only things. There's also the distribution of health resources and how we create inequities through our distribution of health resources. And so in some of the areas where I work, part of what we see in terms of the inequities in a particular health outcome is not because those groups per se are really sort of bearing the responsibility, for lack of a better word, of that difference. It's actually how we've distributed our health resources that is fostering and driving that difference. And so I want to make sure that we see that, and there'll be some examples in my slides later on. And then social conditions. Social conditions matter. We know that the context in which we live, we work, we play, we exist, that context plays a huge role in sort of our health status and what happens to us and what we're able to access in terms of health resources. A little bit about Canada. I'm not an expert in Canada, so forgive me if I've got some of this wrong, but I was struck by looking at some of the data for today's presentation as I was looking across North America. And so I looked at Canada, I looked at the US, I looked at Mexico, and I was struck by some things that were patterns. So one thing that I know very intimately in the US is that the vast majority of adults are living with one or more chronic conditions in the US, and that number is only predicted to increase, and that trajectory is simply unsustainable in terms of the burden, not only in economics, but in terms of human suffering and lack of productivity. Mexico, the situation is even worse. Canada's better, so I would like to recognize that. But I want to point out that 1 in 2 Canadians over age 20 has at least one chronic condition, and 1 in 5 have 2 or more. And I think about the 5 chronic conditions that accounted for 80% of all deaths in 2019. You can see here what would be major targets of areas that if I were a faculty member or leading a school of nursing in Canada, I would be focusing on these issues. They account for a lot, the vast lion's share of the sort of variance or the variability in deaths among Canadians. Canada ranked 10 out of 11 comparable countries for overall healthcare system performance. And this is getting at my second sort of way of classifying inequity, so looking at distribution of health resources. This surprised me. I was not surprised by number 11. Number 11 is the United States. I was definitely not surprised by that. But what did surprise me, and I would be open during the Q&A to some conversation and learning from everyone here, that Canada was number 10. And if you think about higher performing health systems, you can see that there are 9 that are sort of performing at much greater levels. And the discrepancy between the US and Canada is significant, but the distance from Norway to Canada is also very significant. And so important to think about that. And then, a closer look. In my work in the US, obviously, I have an eye towards groups that are furthest from health opportunity and furthest and more likely to experience the inequity. And so in the US, that tends to be racial ethnic minority groups that experience the lion's share of health inequities. In Canada, what was interesting was looking at data that really sort of prioritized Indigenous communities. And again, no surprise, but simply showing the difference between sort of non-Indigenous communities and then some of the Indigenous communities, and the percentage of the population aged 12 and older without a regular healthcare provider. And it seems more pronounced among indigenous communities. And so again, these differences are occurring, and how we understand those differences and what's driving that is sort of the question that we need to ask ourselves. Lastly, I'll talk about social conditions. And this figure, what it's trying to get at is that we know that the lion's share, certainly in my nursing training, was on clinical care. About 20% of the variability in sort of a health outcome is tied to clinical care. But I would say the vast majority of what I learned as a nurse, I would say 95% of what I learned as a nurse, certainly in my first professional degree program, and even in my advanced training as an NP, was primarily tied to clinical care. And there was much less focus on social context. I would say if it weren't for my public health training and my social welfare training, I would have been a little bit absent from that perspective. And that's something that's been really, it's weighing on me, because if you think about this figure, what it's saying is that these large scale events or these social conditions, the context in which people find themselves, that they drive somewhere between 80–90% of the modifiable contributors to health outcomes. And there are many things that have been shaping our world and our countries, some of them being obviously things like climate change or housing instability, global pandemics like COVID-19, issues around mental and behavioral health. You know, in the US, young people in particular have been experiencing huge increases in depression and anxiety. Rights of First Nations and Indigenous people, that's been an area that I think is close to the Canadian experience. And then lots of debates around things like sexual, gender, and reproductive rights. And I can go around the list, and we might change what the circles are for Canada, for another country. But I think what's important is that these social conditions account for the lion's share of the variability that we see in outcomes. And that it's important as nurses that we start to think about how can our clinical care and what we learn and teach, how can it incorporate that 20% that we've got a real sort of footing on, that we do well, but then also the 80% that typically we're not addressing as robustly as we should be. And that may be different here. You guys can correct me if I am wrong about that. But I have been going around the country and now even outside of the US, and I've been providing this lecture to sort of challenge us to think collectively about how we can advance health equity by reimagining our nursing workforce. I'm going to talk more about that. So there are a couple of things that I see as being important in terms of the relational form between these large-scale events and social conditions. Well, the first is that these large-scale events, they sometimes create new inequities. And a good example that we all can sort of relate to is the COVID-19 pandemic. That was unprecedented. At the time, I was working at Montefiore Medical Center and New York University, and you can see here that COVID impacted communities that were most disadvantaged in the U.S. and other communities, but particularly communities that were most disadvantaged. And it created differentials between people who were vaccinated and people who were not vaccinated. We started to see robust differences in who got hospitalized and who died as a function of vaccine status. Well, what's interesting about that is that we also know that there were differences in terms of who could access the vaccine. And in my context, the people who were most likely to be at risk were among the least likely to be able to access the vaccine. You can also see that the large-scale events, while they may be contemporary, they actually brought light into what had not been fully understood by all segments of our society. And so the example here is that COVID-19 really made clear the sort of historical and chronic impact of things like structural racism or any kind of anti-some group sentiment that has been pervasive and has really been part of the fabric of a particular society. In the US, racism has played a huge role in inequities, and COVID made that clear in a way that it hadn't been clear. People saw it as interpersonal, as being more historical, about interactions that were on the one-on-one level. That's not what it is. It's a systematic, systemic, and structural sort of factor that is shaping inequities, and COVID made that more believable to our broader audience. People were questioning that and saying, well, wait a minute, something's wrong here. And then there were sort of synergies that we had not expected and that worsened pre-existing inequities that may have been fairly independent, even if they were not. When they came together, it made it worse. And so a good example is a state like the state that I was just living in most recently, North Carolina. North Carolina had made massive progress in terms of overdose deaths. We had really gotten much better at thinking about distributing Narcan, getting people on Suboxone, dealing with harm reduction, and we had lowered overdose deaths. Well, when COVID hit, we saw that the COVID pandemic interacted in a way that was synergistic with the opioid epidemic, which led to increases in overdose deaths. We can give many examples of this, whether it be, for example, sexually transmitted infections, or I could go through a list of conditions that became worse, partly as a function of us not being able to operate as normal. So things that would have been managed better, your hypertension, your diabetes, your cardiovascular disease, there wasn't a way to do that because we were dealing with COVID and responding as a world with what was most pressing. And so these synergistic effects also have been really critical. It's not just health. There are clearly sort of financial and also human costs. What you see on the slide are the human costs. And so again, the inequities that we see in health status and distribution of resources and in the harmful or detrimental social conditions, they not only affect excessive morbidity and premature mortality, but they also affect society in terms of unfulfilled human potential. When people are more reliant on health and social services, then they're unable to engage and to contribute to the economic well-being of a society, of a country, the way that they normally would. It costs us well beyond the cost of those healthcare and social welfare services. There is a total cost that is much more expensive because we wind up then with not really benefiting from what all of us would contribute if we were at our optimal sort of health status or we existed in that way. There's eroded social cohesion. We become more focused on protecting our interests, more worried about whether or not we're going to have what we need. A good example of this is think about any kind of concern about a supply of things like food products or toilet paper. Think about COVID. You go to the supermarket, it was all gone because somebody came along and took all of it because we were thinking I need to preserve myself, my family, the immediate people in my life versus looking more broadly at what that would mean from a societal point of view. There's excessive bereavement, more people getting ill, more people dying, and so again, unnecessary life expectancy being shortened. In the US, we've seen a reduction in life expectancy that is quite significant, and it's going in the wrong direction. That is also true in Mexico, and it's also true in Canada, though that the drop has been less robust. It's been much more so in Mexico and the United States, but it's true here as well. And then this reliance on caregivers that's unpaid. And so anyone that has a family where you have either someone who is ill, somebody who is aging with chronic conditions, more and more of that care is not happening through our formal healthcare system. It's happening through our families, through our loved ones, through people who in our lives are not being paid to actually care for us. And what that means is that it has a tremendous toll on those individuals that are providing the caregiving. There's a massive cost to this, and these data I was not able to find for Canada, but I did find them for the United States, and I would say that I would encourage folks that are here, whether they be students or faculty, to check these data out for Canada. So Deloitte, the accounting firm, they did this fantastic report that really looked at the costs of inequities today. What is it that we spend as a country in the United States on bad care, suboptimal care, care that is for preventable chronic conditions that if we provided better care, we could avert completely that cost. And what they said is that right now, in 2023, the cost of the healthcare system is $320 billion in bad care, preventable cost that is the inequity, that we could actually use those monies to invest in things that are much more constructive to our country. Each person is paying on average $1,000 a year to maintain bad care. If you project out to 2040, what that number is projected to be is $1 trillion in bad care, in inequitable care, in preventable cost, and it's going to be $3,000 per individual. I will say that while I was looking for data on Canada, I sort of ran out of time before I needed to do this presentation, but I was starting to find data that was quite similar to this, and I was starting to put the puzzle together, and I was hoping that I could have the slide ready. I didn't quite get there, but I will tell you that from my preliminary review, it appears that that same pattern is also operating here in Canada, that there is a significant amount of cost that is going into inequitable care and cost that could be prevented. If anybody is interested in where I got up to, email me and I'll send you the reports that I found. But I was sort of digging down on that and trying to make this point that there is a significant amount of cost that we spend that is not sustainable, that is actually on care that is not advancing our country's health in the United States. So I've mentioned this already. This is not something that is new to us. The National Academies of Science, Engineering, and Medicine came out with a report that said only 10 to 20% of the modifiable contributors to healthy outcomes for a population is tied to our clinical care. And that assumes that we do perfect clinical care, like the best, whatever that means, the optimal clinical care, 10 to 20%. The vast majority is really focused outside of that. You can see it on the left-hand side. It's health-related behaviors or socioeconomic factors or other kinds of environmental factors. Most of what we do in terms of nursing education, from my point of view, is that we focus on that 20% of the clinical care. We've got to change that. We don't want to abandon the 20%, but we want to include the 80 with the 20 so that we can be more effective in terms of what we do. This led me and my research team a number of years ago to start going down a path where we wanted to understand, as good nurse scholars and scientists, what could we distill from those that preceded us. I started the lecture today by saying that this was not new, that there had been many that had come before. Well, we found more than 22,000 articles, and we updated it for this lecture as of 12/5. And so there were 22,065 sort of articles that we found through a search in PubMed. The first one being in 1961 in the American Journal of Public Health, which was entitled Social Determinants of Health Practices. It was pretty flat. There was not a lot of traction on social determinants of health really until about 2010. And then we see this uptick of many more people writing about social determinants of health. And now it's become that there are many more scholars that are actually addressing social determinants of health. So what we did, and I will spare you guys from reading the 22,065 manuscripts, we synthesized all of those papers. And thank you to all of my doctoral students. I see some doctoral students that are here from Ghana who are doing great work. Just think, if you had been working with me, 22,000 manuscripts to go through and sort and distill what could we learn that would help inform what I'm going to talk about today. So what we did was we actually learned a number of things. And I'm going to share with you what we were able to distill. We learned that there was a conceptual evolution in social determinants of health. In 1961, relative to 2023, the thinking was very, very different. So no surprise there, but I want to acknowledge that there has been an evolution that has occurred. The first thing that we saw that was the dominant perspective was that there was recognition early in the literature that social determinants mattered. It seems pretty simple today, but at that time, it was not so simple, that we should be moving beyond just the clinical care focus, that there was a relationship, that there were sort of mechanisms that we didn't understand. We didn't know what the underlying drivers were, but we knew that there was some kind of correlation or association between being in economic disadvantage and poor health outcomes. But what was driving that? And how could we unpack that? And how could we make sense of that? That evolved to another series of manuscripts that really looked at the idea of it not just being an outcome, but there being a disparity. And that these disparities were really these underlying systematic health outcome differences that were clustering in certain groups, and they tended to be the same groups that were experiencing these differences. There was something really interesting that started to emerge, which is another major point that I hope that folks in the audience that are online or here in the room will take away. There was this idea of the word vulnerability. And I remember teaching, my first academic position was at Columbia University, and I used to have a course that was called Working with Vulnerable Populations. It had some title like this. This was back in 2000. And I was so comfortable with the word vulnerable, I thought that it was the appropriate word. But what was interesting about the word vulnerable is that it was opaque, and it doesn't exactly explain, well, why exactly is that individual, that family, that community vulnerable? And would it not make sense to unpack that and sort of see what's really driving the vulnerability. So today I don't use the word vulnerable. I think it's really focused on a deficiency perspective. It may sound great, and some of us may still use it or have courses that have the title vulnerability, but we should challenge it. And in a second, I'm going to explain what my thinking is now about this. The latest sort of evolution of this is that it moved from disparity to really thinking about inequities. And the shift from inequity was that it really highlighted underlying social processes and injustice, and that it was not just about differences that were clustered in certain groups, and it certainly wasn't just about an outcome, which is where the research and the thinking, the scholarship started, that these differences were definitely rooted in unjust and unfair processes. What stayed with that sort of language of unjust and unfair was vulnerability. So then we evolved to vulnerable groups that had unfair and unjust processes. Everybody with me in what I'm trying to communicate? And so again, still focused on vulnerability. So today where we are is our current dominant model. And this current dominant model is how I think about how policies are structured, how programmatic initiatives are structured. We still see the importance, which is a good thing, of social determinants of health. And we are now clear that there is inequity and that this inequity is unjust and unfair. And there's some debate, certainly in the US context, there's a heated debate about words like inequity, but I'm going to say that I believe that inequity is real and that it's rooted in social processes that are unjust and unfair. We've preserved this notion of vulnerability. And vulnerability, it just doesn't cut it. And I think what was interesting about our review of the 20,000 and more articles was that we saw 4 different concepts that were well represented in the literature that didn't appear anywhere in our current thinking about social determinants. The first was a removal of the idea of vulnerability and replacing that with individuals, families, communities are not vulnerable, they are exposed and susceptible. And exposure and susceptibility were constructs that we could actually do something about. I'm going to talk about that. And there's a great public health dean and professor, his name is Thomas LeVeist, who's one of the people, he's down at Tulane, he's the head of the School of Public Health. He's been writing about this quite a bit and has done some of the more interesting work, in my view, around why we shouldn't use vulnerability. Social processes was very much sort of clear in the literature that it was not just sort of the capital aspects or the tangible allocation of resources, whether one had housing or had education or had a healthcare provider. Those were things that, yes, those are social determinants, and they account for an important part of how we understand this work around SDOH, but that these processes were independent of that. Even if you look at David Williams at Harvard University, who has written about this a lot, if we were to address all of the social determinants of health, typically described in terms of these capital kinds of components, housing, food insecurity, health insurance, we would still see inequities because we're not addressing the social processes. And he's documented that in his work. And take a look at what David Williams has written. If you haven't, probably many have, so forgive me for making that suggestion. But it's not enough to just focus on these tangible things. And so I'm bringing into question when we have programs in health systems or in our clinical work that simply link people to transportation or food vouchers. It's not enough to simply do that. That's what I'm getting at. And then there's this idea of resilience, which isn't sort of rooted in sort of the sort of work ethic of countries like the United States. Well, as an individual, you've got to be resilient and overcome. Resilience in the literature is a multi-dimensional, multi-level concept. It's really how do our institutions, how do our societies build programs and policies that foster resilience. It's not about me working harder, doing better, and thriving despite adversity. It's about setting up societies and programs and institutions that will bolster one's resilience. These were things that were missing, and so we sought to try to incorporate them into our understanding of the framework. In those 20,000 plus manuscripts, there were 8 principles that really dominated. I'm going to very quickly go through these 8 principles and take you through what I see as being really interesting about the literature, and you can see them here. The first is that there were these folks, Bruce Link and Joe Phelan out of Columbia, who were writing early on about fundamental causes theory. And principle number one is that social determinants are underlining causes of inequity that we typically don't see. If you look at the little figure on the left, you see the tree. That's what we see clinically. We see what's being presented to us. But underneath that tree is actually the roots, the soil, whatever it is that those little sort of dots are around the roots. And they are not always so apparent to us, but they are underlining drivers. We know that these factors are sort of distal. They talked about them as being exposures, but they shaped individual family community risk, but we didn't understand what the mechanism was. During the early literature with this principle, there was recognition they existed, but how exactly do they affect the tree? An example of this from a lot of the work that I do as a nurse practitioner, I take care of young people who are living with HIV. And so one of the things that I want to illustrate here is just this example. So typically there's a focus on seroconversion. In the US, we have a very ambitious plan to end HIV by 2030, and we focus typically on things like whether or not someone is virally suppressed or they're receiving pre-exposure prophylaxis. Two of our biomedical tools, incredibly effective at preventing forward transmission of HIV. What's less focused on is really the sort of contextual prevalence of HIV in a community and whether or not one is making decisions about sex or drug-using behavior in a context where there's elevated HIV prevalence. What we also spend even less time on is thinking about how these social processes, things like medical mistrust or anti-immigrant sentiment, racism, et cetera, are shaping both the uptake of something like pre-exposure prophylaxis or antiretroviral treatment, and also how those things are clustered, that disadvantage, in contexts where we also see high prevalence of HIV. And so this is simply a way of saying that while most of us, and conference after conference, presentation after presentation, people are talking about how we need to increase uptake of PrEP, I agree with that. But I also think that the network prevalence of HIV, as well as the underlying drivers of why we see poor uptake, as well as high prevalence in communities, also warrants our attention. And too little or too seldom do we see that. Another great example is that the context shapes the health inequity. We typically focus on individual level risk, when in fact, the real risk is a function of a number of things. And so I love using this sort of image of the sharks in the pool. So let's imagine that, Linda, on your side of the room, you are in community A. And on this side of the room, where our terrific colleagues, our doctoral students from Ghana, sorry guys, you guys are all community B, okay? And so if you engage in a particular decision regarding, I'll just use the example of sexual behavior, in community A or community B, for our purposes, swimming, if I'm going for a swim, I'd much rather go into a pool where there's no sharks. But if I have to make a choice, I'm definitely going into Linda's pool, community A, because chances are that the odds of getting bitten by a shark are going to be much less than community B. So let's imagine that one level of opportunity for intervening is not jumping in the pool. We certainly can do that, prevent people from swimming in community A or B. That has been the focus of much of our efforts in terms of nursing, public health, medicine, et cetera, stopping people from going in and focusing on individual behavior. Less focus has been on really thinking about, well, how do we clean up the sharks in community B and community A? And what's also interesting is that when a shark bite occurs in community A, there typically is a response. There may be institutions, there may be health systems that respond, so that while it can happen less frequently than B, there's actually a way in which they can sort of address that and minimize risk. And so context really matters. And you can see in this next image that another quick example, that when we think about seroconversion, which I'm going to keep on coming back to this, it's not just a function of individual behavior. It's a function of the actual risk environment, which is broader, which is sort of exogenous to the individual. It exists outside. It has to do with the physical space. And are there, for example, PrEP providers in that community? What is the proximity or the ease by which somebody can access PrEP. It has to do with norms regarding sort of, HIV prevention and treatment in that community. It has to do with economic opportunities and issues regarding, cost and affordability and policies that really look at things like our laws and our ways in which those policies create either more risk or less risk in certain individuals. And there are great examples of this. You can see in the US that there was an employer in Texas that said that they did not want to pay for PrEP for a particular segment of their workforce because they thought it was amoral. Well, that creates additional risk for those individuals. And there's many, many examples. You don't need to go very far to build on these examples. In this framework of literature, there's also principle number 3, that because somebody has a context that is harmful, or let's say that it is a challenging context. I started my lecture saying that I grew up in the South Bronx, New York City's most disadvantaged borough. I've had a fantastic career and have been able to achieve many great things. Disadvantage is not deterministic. It is not the case that every person that has a certain circumstance in a certain context winds up with a certain outcome. And so another principle that was really evident in the literature was that we could intervene at different levels. We could intervene at the individual level, the micro level, at the institutional level, or in the broader societal level. And at this environment of risk, there were multiple targets to our interventions. Another strong endorsement of the importance of nursing interventions not solely being at the individual level, but thinking about all levels. Here's a great example, right? Back to our sharks in pools. People have historically liked the pool example with the sharks. It's a simple way to communicate this, and it makes the point. So 2 swimmers, swimmer A and B, both are going to swim. Both are going to get into the pool. Both pools now have the same number of sharks, so we don't have the difference in terms of the numbers of sharks. But in swimmer A's experience, there's a lifeguard, there's medical care, there are nurses. Swimmer B, there is no health care, there is no lifeguard. And in swimmer A's case, he or she stays on the shallow side of the pool. Swimmer B goes out further and is swimming closer to the sharks. Well, it turns out this is not very true because there's a lot. I live in Miami, and there's a lot of sharks that come pretty close to where the people are on the shallow side. But let's imagine that this is true. What happens is that swimmer B gets bitten, there's a different outcome because a function of the micro level, certainly the behavior was different, and also the pool was different at the meso level because there weren't institutions that could respond. This is a way of saying that we need to think about all 3, the context of the pool, the institutions and services that we provide to that context and that community, and then also the contribution that is the individual. Great example of contextual disadvantage is not deterministic. 2 people, they both reside in a high prevalence HIV community. One person has access to a health system, one does not. So person 1 does not, person 2 does. Person 2 is able to access PrEP because of the responsiveness of the health system. Person 1 is not. We see a seroconversion on person 1. There is not a seroconversion on person 2, yet both people come from a similar contextual risk, right, of disadvantage. It's just another way of saying that it's not simply a function of the context. There can be variability. Life course really matters. We know that contextual advantage or disadvantage is cumulative, and that over the course of our lives, that our early life exposures to risk or protective factors, that this impacts our health and well-being later in life. 70% of the premature adult mortality across our globe is tied to processes that begin in adolescence. Adolescence is a time that young people are presumably at their healthiest, they're doing well. It's kind of downhill from a health point of view after adolescence, but if you think about it, we wouldn't see adolescence as being a time when we would want to focus on adult morbidity and mortality. Turns out that many of the things that are driving life expectancy to be shortened in adult years across our planet have their origins in adolescence. First sexual experience, alcohol, dietary intake, physical activity, sexual behavior, etc. And so it's really important that the spatial and temporal context and the accumulation of both disadvantage and advantage is understood from a life course perspective. Another major point in the literature. Here's a great example. I work with adolescents living with HIV. Let's imagine that an adolescent seroconverts sometime during their adolescence, and they move into their sort of young adulthood and then ultimately older adulthood. what we see is that there can be a rapid sort of advancement of sort of their HIV disease and other comorbidities as a function of uncontrolled viremia. And so what you see here is that it is not simply the case that this individual is going to look like somebody who's acquiring HIV in older life. They're going to have the cumulative impact of that inflammation and the impact of the virus on their immune system over the course of their life course, particularly if they're not virally suppressed, but even if they are virally suppressed. This is something that I knew very little about, and I don't know, maybe my Canadian colleagues are much more knowledgeable about this, but I knew nothing about biological embedding. And my understanding of biological embedding was really this principle that these social processes like racism, anti-immigrant sentiment, anti-Semitic sentiment, anti-indigenous sentiment, all of these things that are structural social processes that are harmful and detrimental to people's well-being, I saw them as being more social processes. Someone didn't like me. Someone thought because I was Latino that, I was sort of part of a stigmatized, marginalized group. Well, it turns out that a lot of the work that has been happening in this area, Nancy Krieger from Harvard is one of the people who's been working and writing a lot in this. These social processes, they have physiological implications on major systems in our bodies. And so you can see here that social conditions, they initiate and sustain biological changes, both in the short term and the long term, and that these biological changes, we see them in the epigenetic, the neurodevelopmental, the immune, the endocrine, and the microbiome, and that these social processes are actual physiological manifestations. We can see that in people's health status. Well, that's something that was really new to me, because up until this time, I had become very interested in this. I actually saw the socialists being much more about psychological and social. Well, it turns out it is about that as well, but it's deeply rooted in physiological processes. We need to know more about this, and we need to expand our thinking in nursing. This could actually be a way of clinically intervening long before we have clear indicators that somebody is on a course to a chronic condition. Good example here is social determinants of health. Back to our seroconversion example, you can see that there are two pathways. Chronic stress in this case is the social process. It could have been racism. It could have been any social process. You can see on one side, we see that there is a physiological process that actually leaves the mucosal barriers where HIV can attach more vulnerable, enhancing attachment. On the right side, you can see that there's really a sort of a process by which we wind up with more reward sensitivity, and decision-making can become much more focused on sensation-seeking and high-risk sexual and drug behavior. And so again, what's not important is the actual pathway. What I'm trying to articulate is that these social processes and determinants, that they are physiological and they can result in something like a seroconversion or whatever the health outcome is that you're interested in. And us understanding those pathways in combination with the other principles is pretty critical. The family, we focus a lot in health on individuals. The family plays an important role, and this framework of biosocial inheritance was also very pronounced in the SCOH literature. And so there were three basic kinds of biosocial inheritance. The first was the cross-generational, that really looked at how something went from parent to child. That's pretty clear, from mother to fetus or parent to fetus. Then there was the multi-generational impact. And so that makes sense to me as well. If you're a family living in a particular context of disadvantage, and let's imagine in your household that you have the grandparents, the parents, the children, maybe the grandchildren, et cetera, that entire family is experiencing food insecurity or maybe having problems with housing instability. And so it's affecting multi-generationally in one household. And then this transgenerational, which was more new to me as well when I was doing this research or reviewing this literature with my team, was where multiple generations consecutively wind up with similar health outcomes because of the social arrangements, the historical context, the political economic context, because of some of the biological changes that we've talked about already that are happening at the family level. So we see clustering of these inequities in certain families. I won't review this. I'll simply say that in the interest of time, that we have another example of how STOH is demonstrating the multi-generational, the cross-generational, the transgenerational, and how that pertains to seroconversion. Just a way of providing an exemplar of the concept. Two more principles, and then I'm going to start wrapping up, okay? So the first is syndemics. We know that things interact synergistically, that it's not the case that we encounter people that solely have hypertension. We typically see things like hypertension with major depressive disorder. They may also be consuming alcohol and have an alcohol use disorder, et cetera. And so what this is getting at is that in the communities that are experiencing the greatest inequities, we typically see co-occurring health inequities that are clustered and that are synergistically reinforcing one another and making things kind of worse. There are some mechanisms that were articulated in the literature. One was a biological mechanism where there was synergism. So a great example is if you have an STI that is not HIV, you're a more efficient transmitter of HIV if you are in fact living with HIV and virally unsuppressed, or if you have an STI and you don't have HIV, at the site where you have that STI, let's imagine the vagina or the anus, you're much more efficient at acquiring HIV because of the presence of CD4s at that site. So biologic synergism makes you more exposed and makes you more susceptible because of what I just shared in terms of the process. The same is true with socio-contextual synergism, and the example here is that increased risk of sexual HIV acquisition because of substance use and your membership in certain networks that may be high prevalence HIV networks. And so again, just speaking to clustering. The last principle that I want to comment on is really around the unjust and unfair social processes, and again, how these are operating to produce the health inequity. And so in a nutshell, what this is really getting at is this eco-social theory that conceptualizes the health inequity as being biological expressions of social processes. So again, building on that work around biological embedding, where our social positioning based on our intersectional identities, that we are positioned somewhere in society based on who we are. And there are certain kinds of unjust social processes that we are exposed to based on that positionality. And that leads to health inequities. And a good example of this, and I will explain this one, is that let's imagine a seroconversion, and let's imagine you have someone that has a systematic difference in their social determinants of health. Let's say you're a transgender female, that's your identity and your positionality. You may be experiencing transphobia. You may be a person of color who's trans and experiencing racism. Those social processes, that injustice is going to shape differences in tangible, concrete social determinants, like whether or not you can get a job, whether or not you actually have housing, whether or not you're able to go to school, and that those things then have a way of reinforcing one another. That's what the dual reciprocity is in that arrow. And they also shape the chances of your being exposed and being susceptible to HIV in a seroconversion because of what that experience is. So where do we go from here? I went through a bunch of studies, more than 20,000, lots of basic sort of relational forms and then principles, and these ideas that right now, when we had all this on our plates, we didn't know what to do with it. We said, boy, we've done a good review, but what do we do? Well, we put it together and we integrated it into one framework that we are using in our research, in our teaching, in our practice, and that we are applying in the work that we're doing. And so I want to share that with you. And I want to say that this framework is available in an open access paper, which on the next slide, there's a QR code where you can access it. And there's also a video in a Nursing Outlook paper that does a mini lecture that is brief and short that actually says what I said in 40 minutes in like 6 minutes. And so I would encourage you to take a look at that. In a second, I'll put the QR code up. I think some of the innovations that make this different and that really distinguish the work that I presented today from previous conceptualizations is that it's not a static model of someone doesn't have housing, someone doesn't have health insurance. It's a dynamic framework where there are relational forms. Each of the paths that you see in the figure are opportunities for intervention, interventions to be implemented. There's a relational form and a mechanism. It isn't simply poverty and we see higher rates of hypertension. It's how did we get there, and how does poverty influence someone's exposure, susceptibility, the family context over the life course? Are there multi-level aspects to that poverty experience, etc.? There is a focus on family. We've talked about the synergies. There's the life course perspective. We don't use vulnerability. We replace that with susceptibility and exposure. People become susceptible. A great example of that is think about the Mpox epidemic in North Carolina. We had 7 of 10 cases of active Mpox among Black MSM. 7 of 10 vaccines went to non-Black MSM in the state. So total disconnect between who needed the vaccine the most and who was getting it. And so then we saw increased susceptibility. They became exposed because of, for example, imagine that you were an essential worker during COVID and you had to take the bus or the train or go to the hospital, work in food services. You were exposed because of those social conditions. And you can see that the framework is designed to help us to think critically about a particular health inequity and then to map backwards and think about how this applies to whatever the issue is that you are interested in understanding. To think about a set of interventions or an approach to thinking through what you could do that might advance sort of whatever it is that you care about in terms of eliminating that inequity. This Milbank quarterly paper, it's open access, the QR code is there. It explains the massive review that I've done today, that I hope I haven't taken you guys too much on a whirlwind, but there is a really robust paper that really lays this out in a very elegant way that has all the citations and provides a lot of precision in terms of these relational forms and why we focus on the principles that we do. In this Nursing Outlook paper, there is an application, it's also open access, of the model to an intervention. And it actually lays out not the conceptual like the Milbank paper, but the applied. What would this look like if we were implementing this as nurses across different settings? I don't have time today to talk about intervention development, but what I will say is that we've been evolving what makes nursing different. I was really pleased to hear Dean Johnson say that I'm a strong advocate for the role of nurses. I am. I believe that nurses are the key and are the solution to the inequities that we have in our world. And I think there's something important about the kind of care that we provide as nurses that, again, another one of our massive reviews that we're in the process of publishing, we've distilled across many nursing interventions these principles of what makes nurses and the kind of care that we provide unique. It's not just that we're large. It's not that we're time and time again voted the most trustworthy. It's because we do something that actually has value to health outcomes and that we need to quantify that so that we can articulate it. And what you see in the figure on the left are 9 dimensions that really were quite robust in this latest review that I'm not going to talk about today, but we just submitted a paper to Health Affairs, and where we're trying to articulate the value of nursing. And these 9 principles were quite robust among many different nursing interventions. The intervention might be for diabetes or hypertension or for major depressive disorder, but when you pull back the curtain and look at, well, what are they really doing, you see these principles reflected and a deep commitment to whole person health versus a body part or a particular condition. I want to end by sharing with you my excitement for a new endeavor that I'm sort of taking on. I'm in the process of moving to Washington, D.C., and I've been very fortunate to join the Johns Hopkins School of Nursing in D.C., leading up the sort of Institute for Policy Solutions, which is really going to focus on how we can advance the redesign of health in our country. Super excited. I start January 2nd. I would like to ask you guys to connect with us. We've got a website up that is our preliminary website. And I'm going to end by playing a short video that just is something I wanted to share. And then I'm going to wrap up and open it up for questions. Is that okay? Okay. The Institute represents an opportunity to take all of the research that is conducted at the Johns Hopkins School of Nursing and to translate that into policy recommendations and strategies for elected officials and key decision makers.
I believe that nurses should be involved in policy. We are the front line, the first people that patients tend to interact with, and often the most.
But so many patients fall away along the cascade of care. And so we think about how can we tailor a system so that it works more for the human and less for the system.
I've always been proud that I'm a nurse. We have a deep understanding of people's lives, and we also put patients first. And there's so much important work being done to elevate patients' voices.
Policies are really derived from individual stories, understanding those human experiences, and policies need data behind them in order to be impactful.
Who better to make suggestions about policies to improve healthcare than the health professionals that are actually providing the vast majority of care? Thank you very much for your attention. Represents an opportunity to take all the we don't want to hear that again, but thank you very much for your attention. And please, please, this institute is not about Hopkins, it's about the nursing profession. Please join us and stay connected because we're going to need a lot of support and help if we're going to redesign health for our world. Thank you very much.
Vincent, thank you so much for sharing your work and your thoughts and your stories. Don't go away. And now I'd really like to invite the audience here in person and online for any questions or thoughts that they have that they'd like to share with Vincent. And we do have microphones available. Shona can run around. And those who are watching online can submit their questions or their reflections via the chat. And Rebecca will be monitoring the chat. And let me just look around the room with people who are here in person and see if anybody has any commentary that they'd like to make at the moment. Yes, hello, Vanessa.
Thank you so much for your lecture. That was so wonderful, and so congratulations on your future endeavors. It's brilliant to see your video and your future path. I was wondering if you could give some examples of nurses working in different sectors and how they are engaging at tables, policy tables. I think it's a really great opportunity that you mentioned how nursing is restructuring. It's not what it used to be. There's a lot of innovation that we're seeing. And there's a deeply relational aspect to nursing that is not often brought to the fore, as you said in your earlier education in nursing. And so given that that's the foundation of nursing, what examples have you seen from nurses engaging in this work in different areas of care?
It's a great question. So I think I'm going to answer that a couple of ways. Let me first start by saying that I think that we need to examine how we're training our nursing workforce. That as part of sort of entering and continuing one's career in nursing, that we should be planting from day one that nurses are leaders and that we can work across the continuum, not just in terms of acute care, health promotion, prevention, but across different levels of whatever the health system complex is, both at the bedside, in leadership roles in institutions, whether that be in health systems or outside of health systems, and even at the broader level in terms of policies and thinking through how to serve as an elected official, as a leader of a large national organization, et cetera. There's no reason why nurses can't serve in those roles. So that's kind of number one. I think part of what I've seen, I've been at 4 academic institutions. I cannot say, and this is actually my 4th, so maybe I should say 3 because I'm just starting at Hopkins, but I cannot say that that message has been instilled enough in the nursing workforce. I think we are so busy doing the work of providing care that we often don't think of ourselves as the health solutions individuals that are very practical, that can make really good decisions and that deserve a seat at the table to advance our common goal of achieving health in our respective communities and countries. I think the other thing I'd like to share is I think we need more opportunities to actually create pathways for nurses to have the work that we do. You know, when I was doing that review of the nurse-led model, which was the circle with the components, I was astounded by the thousands of nurse-led interventions that exist that nobody knows about, that nobody sees as being sort of transformative in health, and that very little of that work has been sustained and is being implemented at scale so that we can see that that idea that started as a program that was happening in Toronto could really be something that not only the country of Canada adopts, but that the US, that Mexico, that other parts of the world see that nursing intervention as a way forward for improving health. There are so many of those, and it's deeply troublesome to me, and it should be, I would hope, to all of you and those nurses that are not here and to others that are not nurses, that our innovations are not widely recognized, accepted, and really scaled up at the national level. I guess my humble recommendation for those of you that are in faculty positions or working clinically in settings where you can sort of pursue leadership roles, do that. Train the students to be leaders. Start them early in thinking through how they can become involved, not just in nursing organizations. I hope that this won't be offensive to anyone online or anyone who sees this video or people that are here in the room, but oftentimes I spend a lot of time at nursing organizations, and I've been little by little sort of pulling back on that a little bit. Not because I don't love being with nurses, but because that's not where I'm going to be able to achieve the kinds of things that I'm trying to do. I want to be at the meeting where there are no nurses or where there should be more nurses. I want to sit at the table so I can say, well, wait a minute. We've got a position on this, and we have a view, and not just about nursing, but about health and about things that are related to public health, healthcare delivery broadly, refinancing of health, all sorts of things that nurses are perfectly qualified to do. We do have some visible leaders, and so I don't want in any way suggest that we don't. And we have people that have taken their nursing training. Certainly in the US, we have members of Congress, we have people who serve in very high-level positions who identify as nurses, someone like Lauren Underwood, who is a representative and says, I'm a nurse, and has been pushing not just for health, but all sorts of social welfare and health initiatives, but using a unique vantage point of her nursing training. We need more people like that. Thank you, Vanessa. Hi.
First of all, your work is phenomenal. Thank you for everything that you've done. Oh, thanks. So my background is actually in education, and actually quite similar trajectory to your career. And I worked in a kindergarten and then realized there's a disconnect between policy and practice, and went. And I feel as if what you're saying really resonates with me. And one of the things that I've found in the work that I do is that the populations, and I think nursing and teaching is similar in this, is that I really believe there needs to be a culture shift within the population, because both populations and both professions, you're talking about people who are burnt out, who are working really hard, but also they don't perceive themselves as a voice, as capable, or they just, I think that society really does not empower nurses and teachers and the people who are doing this work to feel as if they actually have a place in society to speak about these things, and the background and the knowledge and the everything that you're saying that you bring to this, and that nurses have this understanding that many people don't have. And so I guess my question is, how do we encourage that culture shift? Like, what do we do to give the people who are doing all of this work the energy to also be able to consider the different, determinants, but also speak up and know that they have that voice? And I just find that is usually the disconnect between the profession and the policy. And I appreciate the work that you're doing. I know that it's going to take everyone to feel as if they have just as much a right to say, no, actually, this is my experience and it's valid.
Great point. I guess I would say in a nutshell that we've got to definitely think about training our nursing workforce differently, and we've got to be willing to be bold in our initiatives. One of the things that drew me to Hopkins as I was thinking about sort of what to do after my time at Duke was that Hopkins is right now standing up something called neighborhood nursing. Neighborhood nursing is a demonstration project that will be in Baltimore that is really designed to put boots on the ground nurses in the most disadvantaged communities and at the level of households provide every single family, every single person with access and quality care that is nurse delivered. Well, that's a bold idea, and that was so attractive to me as I was thinking about what I want to be part of. And maybe we won't succeed. I think we will, but maybe we won't, but we should at least try. And if we can make those kinds of changes in our communities, can we think of that as not just being sort of a academic practice kind of initiative, but really a national model for what healthcare could look like for our country? You know, neighborhood nursing, I think, is going to be a phenomenal initiative, and I think those kinds of things should be happening across schools. The neighborhood nursing initiative, I should be careful how I frame this. I credited Hopkins, but in honesty, and this is even better because it speaks to what you were saying, it's really a partnership between schools of nursing in Maryland and the communities in Baltimore. And so each of the deans and each of the schools and faculty that are part of this initiative are coming together with a focus and with a cause, which is this program. That's big thinking. There's so much room in nursing because of our sheer size and what we do that we could be thinking creatively about those kinds of initiatives to demonstrate our value. We must tell our story. We must speak up and tell people not just that we're the most trusted or we're the largest, but that what we do has real impact on people's lives. Thank you. Carlos.
Thank you. Thank you so much for your impressive review of the literature. I wonder how did you deal with the established frameworks, not only the US Center, which I know you cite them, although they didn't show up, like David Williams, Krieger, Link, and Fella, and so on, but those that are used around the world, like the WHO or the Dahlgren-Whitehead, etc. And if you had a critique of them. And then I wanted to make a point that as a realist in the Boston School, I welcome the use of mechanism, which is something that's ignored in a lot of social determinants of health research. But on the other hand, a systems approach allows not only to identify the mechanism, but also the relations that the mechanism support and the environment in which they are. So, for example, when you were talking about racism, you would identify who is involved in this relationship. Mm-hmm. That would be the Fells Point white community and versus the Latino community that's close by of migrants, and that helps, I think, to understand from a systems perspective better the nature of the social determinants of health than just focusing on the mechanisms. As somebody who spent 20 years in Baltimore and most of them at Hopkins, I'm a little bit skeptical about neighborhood initiatives. I've seen them come and go because of the overwhelming structural racism of the city. But that brings me to another
So Carlos, let me get your 3 points first, because I think you made 3 points, and let me try, and then I'll come back and you can give that next point. So
Okay.
the first is, what did I do with the frameworks that currently exist? So the WHO, a great example. There are many. There's the NIMHD. There are many frameworks that exist. So they're reviewed in the Milbank paper, and their strengths, and many of them have strengths, are actually highlighted in that work. So I would encourage folks, if they're interested, to take a look at that. What I will say, and this is an oversimplification, that the vast majority of existing frameworks tend to be static. The WHO is an exception, but they tend to really identify areas that we should be assessing, but they don't provide guidance on relational forms or the things that I've been talking about. So I would say take a look at Milbank. You'll see those represented. This is really our articulation of the literature. It doesn't mean it's the only model. It simply adds things that are not, in my view, in my opinion, that they're not sort of existing in previous versions of it in quite the same form that we have. I think the second point was about really thinking through systems approaches and not just looking at mechanisms. And perhaps I haven't done a good job at articulating the model, but it is about systems. It's about different levels of influence. It's about thinking about these inequities in broader context, but trying to identify what the relational forms are as a way of guiding intervention. I think that while some of these system dynamics ideas make sense, if I think about my core training as a social worker, which is totally rooted in systems and brought from Brenner, ecosystemic models and different levels, it's really good to assess what's going on, micro, meso, macro, but very hard to then define what do you do once you see those points that are sort of, shaping whatever it is. And I think what we're trying to do is, in this first step from our point of view, really ask us to think through, if you were mapping an inequity backwards, what would you see as being ways in which it's impacting family or exposure or susceptibility, and start to maybe take a bit of a stab, for lack of a better word, at developing an intervention that might target some of these focal points. Maybe it's not going to work. Maybe it's not going to be useful, but it certainly advances what is now our thinking. Look at any major report on social determinants. It focuses heavily on static factors: housing, food insecurity, education. What do we do? How do we move things forward? We need to start advancing the work in novel ways. This may not be the answer, but it's our effort at trying to encourage people to do exactly what is happening here, to critique and to come up with their own models. And that would be the biggest honor, to see that other people have mastered the framework and sort of brought new things to bear. I think the piece about neighborhood nursing, we are not naive. These contexts have been historically entrenched in inequities, but again, we have a choice. We can either sit back and observe and think about describing it, or we can think about systemic collective initiatives. And I'd rather try and be part of an initiative that is trying to impact and not succeed than not doing anything and simply recognizing that it's rooted in historical inequity. We're going to try. If we fail, we fail, and we have to keep on going. But I think we're going to make some progress and we'll learn some things. And I'm super optimistic about it. So, Carlos, you want to ask me the next part? And I think, Rebecca, there's somebody online too.
I think we'll just take one question from somebody online, and then we'll need to bring the evening to a close.
Okay.
Yeah, so this question is from Monica, and she just asks, is there currently a specific SDOH federal bill or policy to support?
In the U.S.?
In the U.S.
So I think that there are initiatives. The White House just put out a paper, Monica, that was on social determinants of health. I would check out the White House website, look at what they put forward. It's heavily rooted in static models and describes sort of major areas based on healthy people 2030. I think that is probably the best synthesis of what the federal government is doing. There also have been some initiatives that have come out of HHS around demonstration projects. And certainly there are a lot of uses of something called the 1115 Medicaid waiver that allows for novel sort of uses of Medicaid dollars to try pilot projects. North Carolina is pursuing such an initiative, but North Carolina isn't the only state where they're taking Medicaid dollars and trying to deliver health care using other kinds of social determinants of health, wraparound services. Let's see if it improves access, quality, and outcomes. We don't know, but those kinds of initiatives are sorely needed. Great question, Monica. Thank you.
Thank you. I think we'll have to close in the interest of time. So I would like to thank you all for joining us. It's been wonderful to hear from our guest speaker, and we do appreciate you continuing to connect with the Bloomberg nursing community around topics that are so important and essential to the profession. And as we look forward to 2024 and beyond, with our refreshed Bloomberg Nursing brand and identity that people have seen, I know we're reshaping the future of nursing together, and for that I appreciate everybody's support. Please keep your eye on our emails, follow us on social media, and visit our website to stay up to date with upcoming events. And let me take this opportunity to wish you all the very best for the holiday season. And please join with me in thanking Vincent again for a terrific time.
I love that, by the way. Nice to get out to. It's great. Thank you very much.
Did you have a memory stick or anything? No?
No, I'm good. Thank you.